Hi, everyone. My name is Tian Zhang. I'm a GU medical oncologist at UT Southwestern Medical Center, Simmons Comprehensive Cancer Center here in Dallas, Texas. And today I'll be discussing highlights from ASCO 2026 in bladder cancer for the Springer Medicine platform. In bladder cancer, we've really made tremendous progress with antibody drug conjugates. Our current landscape for metastatic bladder cancer, urothelial cancer, is quite extensive, much better than even a decade ago. At ASCO this year, we saw the 3.5-year follow-up of EV302, which is the registrational trial for enfortumab vedotin and pembrolizumab in the metastatic setting. This trial enrolled more than 880 patients and randomized them to either enfortumab vedotin and pembrolizumab or to frontline platinum-based chemotherapy. So that's either cisplatin with gemcitabine or carboplatin with gemcitabine. Of note, in the intention to treat population at 3.5 years, 44% of patients were alive. And for those patients who had complete responses, about 83% of patients were alive at 3.5 years. These data for survival in metastatic disease in urothelial cancer is truly quite transformative and something I think we can only achieve by using enfortumab vedotin and pembrolizumab in that frontline setting. And I hope overall that patients have more access to these treatments in the frontline. Now, as we are incorporating enfortumab vedotin and pembrolizumab in our frontline therapy, there is, of course, going to be a discussion about resistance patterns and how do people behave on chemotherapy in the subsequent lines. At ASCO this year, we also saw subsequent treatment with chemotherapy from the EV302 trial. And of note, less than 50% of patients received any subsequent therapy, including about 30% of patients who received a platinum-based chemotherapy. When patients received that platinum-based chemotherapy, the objective response rate was about 20%. And of note, these 20% of patients, I think, is a little bit low than our expected platinum sensitivity in EV pembro refractory disease. But certainly, we should be thinking about using chemotherapy for these patients who have been pretreated. When we're thinking about resistance, we're always thinking about, are we losing sensitivity to the ligand in terms of Nectin-4 expression, or are there other pathways involved in resistance? Are we losing sensitivity to the payload? And what we saw in ASCO this year, there were several posters, including some of our own work, that was showing Nectin-4 is still on the cell surface of patients who are refractory to enfortumab vedotin and pembrolizumab. But there are also upregulation of other antibody drug conjugates, such as TROP2, HER2, and others that we should really think about in sequential treatments. Now, one of the phase 1 trials that read out, though, Nexus-01, was in the EV pembro refractory setting using an antibody drug conjugate with Nectin-4 target and a camptothecin 98 payload. They treated 95 patients with metastatic urothelial cancer. Of those, almost 70% had prior enfortumab vedotin with or without pembrolizumab. And importantly, in that patient population who did have prior EV refractory disease, they saw 31% of those patients had objective responses to this Nectin-4 targeting therapy, delivering a topoisomerase inhibitor payload. So in this particular setting, these patients still retain their Nectin-4 sensitivity and were resistant to the payload. And this subsequent antibody drug conjugate salvaged some of those responses. We can't talk about the current treatments for bladder cancer without considering the earlier perioperative setting. Earlier this year, we saw the enfortumab vedotin and pembrolizumab combinations in that perioperative setting, both with EV303 as well as with EV304 or KEYNOTE-B15. There was a highlight with Matt Galsky did also present the subsequent follow-up of B15, and we won't cover that here, but importantly, there were about 57% pathologic complete responses from even pembrolizumab given in the perioperative setting. And at ASCO this year, we also saw using durvalumab to chemoradiation. This was a phase 2 trial that Nick James led out of the UK. 55 patients were treated with durvalumab in addition to mitomycin C, 5-fluorouracil, concurrently with radiation therapy. And they found at the 12-month disease-free survival endpoint, 83% of these patients were free from disease progression. So really important for perioperative settings and considerations of bladder preservation for this patient population. The last highlight I'll just touch on is the perioperative SHRA2102 trial with adabrelumab. This is another Nectin-4 antibody drug conjugate linked to a topoisomerase inhibitor coming out of China. In this phase 2 trial, there was a pathologic complete response rate of 48%, and I believe, given all the successes and wins that the Chinese populations have had thus far with these antibody drug conjugates that are novel and adding in their own PD-1s, PD-L1 inhibitors, we will see more and more of these trials coming along and considering options for when patients might be able to preserve their bladders. And to that end, there are several ongoing trials in the US that are enrolling for localized muscle-invasive bladder cancer and considering bladder preservation options. The first one is GU15, or also Archer, randomizing patients to different chemoradiation with different radiation settings. And then the second trial that's ongoing is the BRIGHT trial run out of SWOG, which is a one cohort treatment with radiation and pembrolizumab after patients have achieved a good clinical response to neoadjuvant therapy. And that trial does allow neoadjuvant enfortumab vedotin and pembrolizumab. It's certainly been really exciting both for kidney and bladder cancers this year at ASCO 2026. And I hope this segment's helpful, and thank you so much for tuning in.